We can get started. Welcome to the Essential Substance Abuse webinar series. I'm Kate Trams, and today we have Steve Steine presenting on clinical evaluation assessment. Oh, you know what? I don't have all of my intro slides, but I should know them by heart by now, so I'll just talk everyone through them. So we are the Native American and Alaska Native Addiction Technology Transfer Center, and we are part of the Addiction Technology Transfer Center network. There are 10 regional centers and a network coordinating office, as well as a Hispanic and Latino Addiction Technology Transfer Center. So all of that information is on our website. If you haven't visited that before, feel free to visit. It's at attcnetwork.org/native. And just so everyone knows how this system runs, we in order to kind of keep things as simple as possible, we don't have audio rights for all of the participants, so we count on you to use the chat pod to submit all of your questions. There's going to be a few times that we're going to have poll questions today, so we'll be pulling up a little polling opportunity for you a few times during the presentation, so we'd love to get your feedback there, but please submit questions to the chat pod, and then Steve will address them either at break times or throughout, depending on how things work. I do want to let everyone know that we have a survey that our funder has provided. It was created by SAMHSA, and so we would greatly appreciate you taking a few minutes and letting us know what you thought of today's presentation. And I just wanted to throw it out there that there is a comment section in that. And one of the things that we would love to hear in the comments is how you feel about this being a program that is specifically meant for Native Americans and Alaska Natives, and you know what that means to you to have a program that's specific for this population. I think that's especially important for our funders to know about. If this is important to you, then we would love to hear some of that in the comments especially. So I would greatly appreciate you taking a couple of moments to do that. We should be redirecting you as soon as we close out to this, to that survey, but if you don't get redirected, we also have follow-up emails that will have the link included. We also have a recording of this webinar. You can view it at a later time, and handouts that we'll send to you in that follow-up email as well. So with all of that, I want to introduce my partner in crime, Steve Steine. Steve has been working in addiction and mental health for many years now, and he has a great level of experience in this area, and he's a great trainer, and he's been working with us here at the ATTC since last January. So we are so excited to have him, and I'm going to let him take over from here. Thanks so much.
Thank you, Kate. I appreciate that. And a wonderful introduction. And I want to just say good morning or afternoon to all of you who are listening. I do see a few familiar names on the attendance roster, so that's nice. That's a good sign for me as I'm getting new to this position and getting to know and learn about some of the tribes around the country. Seeing a few familiar names is reassuring to me. So glad you could all join us. I do want to thank the Native Center for Behavioral Health, ATTC Center here in Iowa City, and of course SAMHSA for funding us. And I also want to just give thanks to Creator for allowing us all to be here today and to be part of this. Oh,
I'm going to increase your volume because I think great. I'm a louder talker. See what people think.
How about that? Can you guys hear me now? Oh, is that better? Okay, Kate has adjusted the volume. So I wanted to say thanks to Kate for that wonderful introduction, and also wanted to just say good morning or afternoon to everyone who has signed up and listening. And I can say that I do have noticed a few familiar names on the attendance roster, which is a good sign for me as I've taken this position early in the year and getting to know some of the tribes and tribal members across the country. It's nice to see a few familiar names on the roster. So appreciate you all attending today. I want to again thank Kate for the wonderful introduction, and I also want to thank all of you for signing up and listening in today. We have a lot of slides to go over. I'm really looking forward to sharing some of this information with you. For some, it may be review, and for some, it may be some things that you're getting exposed to for the first time. I also want to just thank the Native Center for Behavioral Health, ATTC here in Iowa City, and all of our regions across the country. And of course, I want to give thanks to Creator for making it all possible. And he is here with us now, and I can feel him. So really glad to have all of you here, and hoping we have some time to take some questions, and hope that we have time to have a little discussion. I wish I could see you all and engage with you a little more directly, but we're going to do what we can do. So again, as Kate mentioned, we do have a survey at the end of today's webinar. Please take the time. It's pretty brief. Just take the time to fill that out. That'll help assure our continued funding and continuing to be able to forward and share this information with you. So anyway, my name is Steve Steine. I am a certified addictions counselor. I also have my master's degree in counselor education. I've worked prior to this job. I worked for 23 years at a behavioral health substance abuse treatment center as both a clinician, manager, and administrator, and have just recently come onto the team here, and am really enjoying learning about the Native American tribes and meeting tribal members all over the country. It's really been a wonderful experience thus far. What I can say as we get ready to go through some slides, a couple of things. Just this information has not been culturally adapted. What we're going to share here and talk about here really is sort of the mainstream kind of Western view of evaluation and assessment and the diagnostic DSM-5 manual. So we are aware and have some culturally adapted material along these lines of discussion, but this is not going to be that today. This will be more sort of the standard westernized view on this. So just keep that in mind as we go, and really appreciate it again, everybody being here. So just going to take a minute here and wanted to just offer thanks to Creator for allowing us to meet today. Okay, so let's jump right in. Really, we're going to build on what we talked about last month, excuse me, where we talked about the assessment process from a screening perspective. We're going to build on that today. I'll reference screening several times throughout the PowerPoint, but we're going to really focus more on the evaluation process. This will in turn lead to our final webinar next month, where we talk about treatment planning as it relates to the assessment process. So this is a build from what we did last month. Those of you that were with us last month, we're going to build on that idea a little bit. So today, I've got a lot of slides. I'm hoping that we can get through them all and have some time for questions. So wanted to just kind of look over what we plan to do today, our goals today. Really what I'm hoping to do is define the assessment process, identify assessment instruments, also look at DSM-5 criteria for substance abuse and dependence, which is now substance use disorders, mild, moderate, and severe. Those specifiers, and we know that there is no longer multi-axial assessment, so I'll probably have to make an edit on that slide as well. And then I want to spend some time also looking at the ASAM criterion, the levels of care, and the diagnostic and dimensional criteria that are associated with that. So we've got a lot to kind of push through. I'm happy to announce that I've brought back the polling question. So we're going to do some polling questions as well, just to kind of get a little bit of interaction with the audience. So let's proceed. What is assessment? Well, assessment is the systematic process of interaction with, I'm going to make sure, Kate, that I can see my notes section here. Oh, there we go. I just have to switch it over. Got it. Perfect. Thank you. The assessment is a systematic process of interaction with an individual to observe, elicit, and subsequently assemble the relevant information required to deal with his or her own case, both immediately and in the foreseeable future. This differs from screening, and we'll talk about that. This information gathering interaction with the patient is the clinical building block for everything that we'll do moving forward. Without an initial assessment, we really are flying blind. So really think of screening as really determining whether or not an individual needs an assessment. And the assessment really is the gathering of that, and once it's been determined, is to gather the information and the details needed to then develop treatment planning and moving forward. So these are all interrelated and connected. So again, we're going to look at this this sort of sequential assessment process. So we have screening, we have the problem assessment or the assessment initially, and then personal assessment, which is really that treatment planning aspect. That's sort of a broader view. And then I want to look at this. I used this similar graph last month when we talked about screening, and you can see here that both time and resources increase exponentially as we move through this sequence. So screening, evaluation, and treatment planning all have involve more time and more resources. So as we move from screening to problem assessment to personal assessment, the extent of information developed is greater, but the costs of assessment are also greater. So, but it's necessary to make sure that we are gathering the information we need as the patient's use disorder or mental health disorder becomes more complex or acute. Does that make sense to everybody? And then let's look at this also, this multi-dimensional assessment. This information is sought along three sort of lines or three avenues. When I'm thinking about a substance use disorder evaluation, we want to look at the use of alcohol and drugs, the signs and symptoms of alcohol and drug use, and the consequences of alcohol and drug use. An initial step to ensure the patient meets the level of care by gathering the patient's medical history or previous treatments or current therapy or prior use. This to me would include comprehensively also medical background, behavioral information, social and financial. Really important to see the whole picture when we're beginning this evaluation process in the assessment sequence. Content of screening. So again, we're going to step back a minute and look at the screening process. The screening, remember, allows us to move forward into the evaluation process. So screening, a brief process that answers two questions: whether alcohol or other substances, if there's a problem present, and if so, is it likely to require brief intervention or formal treatment engagement or intervention. All right, let's do a polling question now, Kate. Let's give the listeners a minute to look at this question. So, true or false? Collateral information when assessing a patient's needs is rarely required to determine an accurate diagnosis. Let's give you guys a minute to think about that. And then we'll see what.
And if you didn't notice, we opened up this question in another little box next to the chat box, so you can vote there, and then you can kind of see what everyone's voting for as well.
It's so nice to have polling questions back. I don't know whose idea that was, but it's brilliant. Okay, I think we're close here. Still a few, looks like we have a few more people logging in. Okay, let's see what we have. So, do we have those results up, Kate?
Yep, can you see them now?
I can see them. I didn't know if the viewers can see them or not. Yes, we have decisively decided as a group that answer is false, and you guys are right. So, well done. Absolutely, collateral information is vital to help in determining diagnosis and course of treatment. So, very, very important. Well done, everybody. Let's keep moving. Content of problem assessment. So this examines problems attributable to alcohol and or drug consumption or intake. So we really want to look at three techniques to gather this information and get a good overall comprehensive perspective on this. So there's retrospective methods, prospective methods. In other words, past use and potential future use or potential problems, and then using laboratory results to also assess the level of problem or acuity. So the content of problem assessment. This really is relying on the signs and symptoms of the substance use disorder as described in the DSM-5, 490 and 491. I have that page marked. I love to just open it up once in a while and just take a look at it. There are the big 11, the 11 criterion used to determine a substance use disorder, mild, moderate, or severe. These make up the DSM-5 criterion. And you'll see sometimes in screener questions, you may see some of these 11 criterion being worded in self-report questionnaires. So that happens sometimes. If you're familiar with some of the different screening tools out there, we'll talk about those in a minute. But cross-referencing self-reports and collateral reports, such as arrest records or lab results, can often give a more accurate clinical picture of the patient's overall alcohol and drug use history. Also going to start looking at amount and frequency. Remember that amounts do matter. I had a patient years ago that I was doing an evaluation with, and They were experiencing withdrawal symptoms, early withdrawal symptoms, reported significant tolerance. And when I asked them how many drinks they were having a day, they said, well, just one. And I said, that's interesting. I'm surprised that you would be having some of the symptoms you're having and still only have one drink a day. And come to find out, as we explored more, the drink that the patient was having was actually a 48-ounce cup, half filled with vodka and half filled with orange juice. So that was their daily drink. So amounts do matter. Frequency is also important, but it really is important to keep in mind the relative nature of amounts consumed. Content of problem assessment. Consequences of their alcohol or substance use. We can look at different screeners to determine this, and which may then lead us to that formal evaluation. There's several of these that will borrow from DSM-5 criterion to determine that. I'm familiar with the audit. I know that in AccuCare, for a lot of the IHS services, the ASI is a primary evaluation tool. The DAST I've also used. But these will allow us to start to understand how and what the consequences have been related to the person's substance use disorder or potential for that. So the MAST has 22 questions. The audit has 10 questions. And the DAST, I think, has maybe 20 questions on it. These are screener questions that can lead us then to a formal evaluation. Content of personal assessment examines problems to determine if they are attributable to use. So we're going to look at how these other areas are being affected or impaired by a person's use. And then there's quite a few different areas. We're thinking biopsychosocial, we're thinking holistically here. Content of personal assessment. So here we start to formulate and begin to develop possible treatment goals that we'll talk about treatment planning next month. But even in this portion, we're starting to look at potential treatment planning. So use of leisure time, demographics, family history, cognitive function, different personality traits, treatment goals, situational factors, spirituality, the connectedness to your community. There's a variety of things we can look at. Where they come from, population, from the community, and then just looking at overall, cognitive functions, memory, attention, language, those types of factors. Overview of assessment process. So really, we can look at it in five five ways that now I see somehow turned into six. So I really need to change that to six. But I think recovery capital really is kind of an overall assessment. But let's look at detection, classification, functional assessment, functional analysis, and treatment planning. And then that recovery capital is sort of really assessing both internal and external resources that will really predict or let us understand how likely it is that the patient can have a sustainable recovery after their primary care or primary intervention. And the recovery capital is something that we see talked about. It's the depth and breadth of internal and external resources that can be used by someone to begin and sustain wellness from addiction. Let's talk about drug testing. One of my favorite topics. I collected gallons of urine over the years at the clinic, so I thank you very much. it is an absolutely vital way to make accurate determinations. And really, for me, the drug screening was always an empowerment opportunity for the patient. That's how I viewed it, rather than a punitive measure, which it's often viewed as. Let's talk about drug testing. And look, Kate, we have another polling question. Um, let's see. What is the most common form of drug screening test performed in most substance abuse treatment centers in the U.S.? Let's open that poll up to the group and see what we come up with. Oh, looks like we're going to a unanimous vote here. I can see the I may have to make these polling questions a little tougher. Or you guys are just very got a lot of experienced clinicians here in the crowd, so yes, thanks, Joanne. I agree. There's a clue in the image behind the question there, next to the question. So I just realized that. Oh, that's good. Oh, Kate, yeah, Kate's taking Kate is taking credit for that. Yeah, so we all know the answer, of course, is C. It's the most common and probably one of the more reliable and less cost prohibitive means. So detection, identify a patient with potential problem, past and current use of alcohol or other substances, lab tests to screen for substance use, and then the negative consequences connected to that. Classification. So here we start to look at, I think part of the human condition is we're driven to classify or categorize. I think more so probably in Western approach or Western sort of perspective, but in a diagnostic or clinical setting, oftentimes being able to classify is important for billing. It's important for determining level of care and the treatment course moving forward. So in classification, we're assessing possible DSM-5 diagnosis, really trying to hone in on uh, the worst period of the patient's use, or when they were really at that low point, if it was a slow decline or a quick progression, and then using multiple sources of information to help classify and categorize their substance use disorder or other co-occurring or comorbid issues. Functional assessment. Obtain patient information. Use all available collateral sources. Assess the patient's range of different needs. Identify the patient's strengths. Strengths can be of use to get and to help incentivize the patient to stay on course and consider making some changes. Also identifying the patient's support system. Culture is seen as a strength and can really be a vital part of that patient's support system. And it can be a protective factor too, from a prevention perspective. And then identifying the patient's recovery capital. Again, that's tied into that idea of what internal and external resources do they have that might help sustain their recovery, especially early on when they're vulnerable and susceptible to relapse or return to active use. Functional analysis, identify factors that maintain substance abuse or substance use, explore possible motives. If if I sit down with a patient and I say, tell me what it is that you like about cannabis. Tell me more about that. That's going to help me look at that, the possible motives, the reasons behind why they maybe started using in the first place. If you identified motives and costs, as working hypothesis, not as fact. So again, what would happen if you continued on this path? What would happen if you continued to drink daily, and really working towards possible outcomes, letting the patient explore those collaboratively with you. But that's another discussion. Methods of obtaining assessment information. So we have the classic sort of face-to-face interviewing. That's really a very popular and reliable method. There's the semi-structured interview and structured interview. Can be a little more formal. Paper and pencil tests, and then of course moving to this electronic records keeping. A lot of the electronic health record systems now are all fully virtual and fully computerized. So the day of the paper and pencil tests, may be short-lived, but I know in some areas, some rural areas, especially in Indian country, I know there isn't always access to internet or reliable computer access. So having pen and paper backup is never a bad idea. I always carried one when I went into the jails to do evaluations in case I couldn't access the network while I was in. So anyway, let's keep going. Let's look at some assessment tools. So again, I referenced these earlier, the Addiction Severity Index. This is the primary evaluation tool used in AccuCare, and it's also used in other agencies around the country. It's a semi-structured interview, assessing a variety of things, as we can see there. It's very comprehensive. That to me is always a good indication of an assessment evaluation tool. It has a comprehensive nature to it. There's also the CDP. Again, I'm not as familiar with this one, but it's a structured intake interview, really looking at history and current status of drinking problems and related issues, and then looking at amount of frequency and problematic behaviors associated with that. I'm not as familiar with that. I don't know if anyone else has utilized that evaluation tool or not. So let's look. Then there's the this one is interesting. I've used this more informally, but the timeline flowback really it helps the clinician and the patient analyze patterns, intensity, and frequency, and connections between use and significant events. Using a calendar or common holidays or seasons can also be an effective means to establish an accurate timeline, or what we would call like a temporal anchor. Sometimes if you have a patient that is having difficulty with memory or may be unwilling to be truthful at the time, sometimes using the temporal anchors can give you a little bit better picture and accurate information. The IDS, again, this is another evaluation tool that I'm not as familiar with, but assesses situations of heavy drinking, examines 8 categories. You can see those listed out there. I'd be interested in looking at a version of this and seeing how it's scored, or how the outcomes are determined. But it looks, again, it has a comprehensive nature to it for sure. Looks like it focuses though primarily on excessive alcohol use. This is the situational competence questionnaire. Again, this is a self-report instrument. You might see this given electronically, where the patient just imagines themselves in each situation, and then it's rated on a 0 to 100 scale, how likely they will be able to resist the urge to use substances in that situation. So this again could be a supplement to something you're already doing assessment-wise, or a supplement to something you're working on with the patient to reduce risk or prevent relapse. Substance abuse subtle screening inventory. It's a one-page self-report screening. It has an element. This is the SASE. I think the SASE is utilized. I know we have a clinic here in town that utilizes this. It has an element where questions are asked in different ways to see if there's any deception or misleading on the part of the patient, and it identifies individuals who may be maybe at a lower readiness to change or deliberately trying to divert or protect their substance use. I don't know if anyone's used the SASE. It's pretty popular. So, and then the GAIN. I do have a little experience with the GAIN. The GAIN is a very comprehensive interview style format. There's one designed for youth and adults, but it's probably a 2.5 hour interview. Very, very extensive, and it's just a series of questions covering all of these different areas. Very, very comprehensive. We used it for a long-term study with youth when I collaborated with the university years ago. It's very comprehensive and easy to gather data and look at it. We're going to shift gears now. Hope everyone's holding up. And there are, Roxanne, there are a lot of links online to some of these assessment tools. I think in order to administer the SASE, for example, I think you do have to go through a training, or it's something you would need to be trained to administer. But there are a lot of resources and links and a lot of different assessment tools. It's easy to get overwhelmed sometimes. Let's look, though, I want to shift and look at the DSM-5. This diagnostic manual was revamped and updated, as most of you probably know, in 2013 and rolled out in 2014. They made some really significant changes, I think, in the way they look at diagnosis and some of the language that they use to describe and determine substance use disorders. But let's take a look. Substance-related disorders in the DSM-5. So there are 10 substance-related disorders, and they're listed out here. And I'm sure this information is all available in the DSM-5 manual or the desktop manual, and readily available online too. But there are sort of the big 10. So we're going to go right to a polling question. Now this I know I haven't given you much on the DSM-5, but let's see how we do. Polling question: how many diagnostic criterion are listed in the DSM-5 section for substance use disorders? How many diagnostic criteria are listed in the DSM-5 in the section for substance use disorders? Got a couple minutes here. I don't think there's any clues in that picture, so I think, Kate, I think you're okay on this one. Okay, we're close here. We're close. All right. So the correct answer is B, 11. So there are 11 diagnostic criterion listed in the DSM-5 when trying to determine substance use disorder. So the answer is B. You guys did a nice job on that too. I've got some experienced clinicians in the house, so well done, well done. Let's keep going. Substance use disorders. Now, again, as I said, this is really looking at it from a very standard mainstream approach. And for some of you, this may be review, and others, it may be something you're looking at for the first time if you're interested in the field or looking to get into the substance use disorder treatment work. We need a lot of people. We need a lot of clinicians coming in. So especially to see young people coming into this helping profession, because substance use disorders will continue to be part of our culture and society across all cultures and society. Substance use disorders. Almost all substance-related disorders in the DSM-5 include the disorders, intoxication, and withdrawal. Almost all specify that substance use disorders be rated mild, moderate, and severe. That's a change from DSM-4-TR, where they were identified as abuse or dependence. The exceptions include the following. There are no intoxication or withdrawal ratings or severity ratings for some of these other substances listed below. So, and that's pretty self-explanatory if you think about it. Alcohol use disorders. Alcohol-related disorders include alcohol use disorders, mild, moderate, and severe, alcohol intoxication, alcohol withdrawal, and unspecified alcohol-related disorder. The unspecified alcohol-related disorder, as some of you probably remember, replaced the not otherwise specified NOS we saw in DSM-4-TR. Essentially, though, the unspecified related disorder simply says the patient, there are concerns related to their alcohol or drug use that don't necessarily meet the mild, moderate, or severe criterion, but it's still enough. There's enough concern there to merit a diagnosis for further exploration. And as I said earlier, the distinction between alcohol abuse and dependence has been eliminated in DSM-5. So both of those terms have a negative connotation. So I'm glad to see them shift to mild, moderate, and severe. Polling question. Look at that. We're just going crazy with polling questions today. We haven't had them for a while, so I thought I'd better get a few in there. Polling question. If a patient has a diagnosis of alcohol use disorder moderate, how many DSM-5 criterion would they need to currently meet? Okay, we're getting close here. And as I'm looking at this question, I may need to change this one up a little bit because it might be a little misleading how I worded it. We have everybody in, or we still have some votes coming in? Okay. So I put the correct answer as D, both B and C, because the moderate diagnosis is 4 to 5 criteria, but you would only need to meet 4 as a minimum. So maybe I need to just change that over to B instead of D. Does that make sense? Though 4 or 5 are needed. 4 to 5 criterion are needed to meet a moderate diagnosis in DSM-5. Okay, I may have to adjust that one. If anybody wants to protest that answer, they sure can. I'll use that as a basis for changing that. Let's keep going. Alcohol use disorders. So here we have it. Mild, moderate, and severe. Of those 11 criterion that we talked about, the big 11, you see here 2 to 3 symptoms present for a mild, 4 to 5 for a moderate, and 6 or more symptoms present for a severe. And remember, we're looking at this occurring within a 12-month period. This is important to look at this within a 12-month period. When I trained and trained others, I tended to focus on the most recent 12 months, but you could certainly move that back further and look at another 12-month period. But I often felt that the 12 months leading up to their evaluation really seemed to make more sense. So Alcohol use disorder. Alcohol use disorder is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by, and then we have, there's 2 of 11 listed symptoms and occurring again within that 12-month period. Symptoms of alcohol use disorder. I don't think we need to go through these verbatim, but they're really broken down. And I think the key when looking at these, everyone, is to look at there's an element of this where you are looking if it's a repeated pattern or a recurrent pattern. So you really want to see recurrence happening in these symptoms, so it's not just a one-time event, but it should be a recurrent element. These first 3 are really looking at how the person's being impacted, how their life is being impacted, and if they have loss of control. The next couple we're looking at, craving was added. Craving was added in place of repeated legal problems because they felt repeated legal problems related to alcohol or drug use was bias to certain populations and ethnicities. So it was removed and replaced with craving. Then we have recurrent alcohol use resulting in failure to fulfill a role obligation. And we move through 6, 7, and 8. Again, we're looking for recurrence. We're looking for recurrence in these symptoms happening. Recurrence to me is 2 or more times. 9, I think this is an important one because we have continued use despite, let's say, a medical condition or a psychiatric condition that's only making the matter worse. Very, very important determination when assessing that information with a patient. And then lastly, just tolerance and withdrawal. And again, I think the tolerance is extremely important to note. And then also withdrawal. And I always remind clinicians that withdrawal from alcohol or another drug class called benzodiazepines can be life-threatening. So I always say if we have signs or symptoms related to active withdrawal, we need to have them medically stabilized. It has to be a priority. I'm sure most of you are aware of that already. It's just a friendly reminder. Specifiers. There are some remission specifiers, and I was really happy to see in DSM-5 they reduced these to 2. There were 4 before. This is now it's just simply early remission and sustained remission. So it's much simpler. You just look at them not meeting criterion for the last 3 months, but less than 12, and sustained is more than 12 months, 12 months or more. I want to just briefly look at the ROSC, Recovery-Oriented System of Care. I think this is important. Thinking about the future of our field, I see one new trend that keeps coming up, and I think it's very promising. It's the recent shift in thinking away from clinical treatment model towards a more recovery-oriented system of care. I think we're going to see this play out more and more. We focus not only on recovery from addiction and its negative effects, but we also focus on recovery of meaningful life, purpose, community, and that overall wellness. This is where the field is moving, and I think it's a good thing. Just briefly, just sort of looking over this shift using the ROSC model. It's rather than how do we get the patient to treatment, how do we support the process of recovery within the person's environment. So it's thinking more globally, more broadly, rather than just this myopic idea that they have to go into treatment by default, into a formal treatment setting. Okay, here we go. Polling question. Which of the following is not a key component of the ROSC approach. Which of the following is not a key component of the recovery-oriented system of care approach? Oh, you guys are good. You guys are pretty good. Yeah, I think what we need is some of that Jeopardy music going during the polling questions. That would make it a little more exciting. And you guys are right on with this. The answer is, of course, A. Not working separately, but working collaboratively or together. These support systems would work together and compare notes, and there would be overlap and enmeshment of those. But it builds on the strengths, offers a comprehensive menu of services, and adjusts to the patient's pace and recovery process. Very important. I think this gentleman to the left there would agree. Again, I don't want to spend too much time on this just due to time constraints, but kind of look that over. If you're interested in ROSC system of care, more information about that, I can certainly connect you. Here we have this idea, this connective idea. And then we broaden that out and fill in some of the services and supports within that recovery circle. These are great visuals, by the way, Kate. Thank you. And again, it's person-centered and self-directed. Builds on the patient's strengths and the resilience in the patient. Involves family, some comprehensive menu of services, and adjusts to the patient's pace. Really looking at outcome-driven approaches to care, ongoing process, system improvement, and involvement in the assessment process. The patient is really an equal partner in this. I've always tried to involve the patient in that evaluation and assessment process as much as I can. The more you involve the patient, the more meaning and purpose it has to them, and the less likely they are to feel unsafe or unsupported. And again, there's just some more qualities about the elements of the ROSC approach. And just some of the other elements that are a real pro. I think the continuum of care is very important. You front load a patient's services in assessment and primary care, and then really when they need it the most, during maybe their step down or their continuing care, you see all the services peel away. It's like saying, oh, the patient's getting better, let's take away their services and see how they do. And that shift away from that, I think, is what we're going to see in the next decade. Is more sustainable, holistic, and ongoing support. Okay. Let's see if we can't. Kate, I want to say, do we have a little extra time? Can we go over a little?
We have until 1:30, Steve.
Okay,
So,
perfect. Well,
yep.
that's great. Okay, wonderful. So we should have. I'm going to do my best to see if we can't move through this. I really want to spend some time talking about the ASAM criterion. Very important concept, especially in the addictions field. The ASAM criterion, as we're going to talk about, really are not a standalone assessment guide, but really a supplement to your primary assessment tool. It really affords the clinician or a team or a clinic an extra layer to provide consistency, accuracy, and that idea that it is consistent and it's almost like a language that you would speak with other clinicians and be able to use the ASAM criterion to better serve the patient and identifying their needs and diagnostics and level of care. So let's see if we can get through a polling question. Oh my goodness. What does ASAM stand for? Now, some of you that may have had some engagement with ASAM will know this. But let's see. Oh yeah, you guys are pretty good. I may have to beef up these polling questions a little bit. No, you guys are all pretty good there. Yeah, yeah. Very nice. Very nice indeed. So, yeah, ASAM is American Society of Addiction Medicine. So the answer is C. Well done. American Society of Addiction Medicine. ASAM, around 1981, the along with the National Association of Addiction Treatment Providers, assembled a task force and really started to lay down these criteria, these continued stay criteria. And then the NAATP decided to sort of relinquish their rights, and ASAM took them over and has run with them ever since. The goal of the ASAM is to unify the addictions field around a single set of criteria. So this has this sort of universal language component to it, and it allows for treatment center on the West Coast to make a referral to a treatment center on the East Coast and still have the same unified, universal, consistent criteria used in that referral. Now, I know that in talking with some of my Native brothers and sisters that ASAM criterion are not required when making referrals within IHS, but I think the ASAM criterion would be vital when you're referring out or to a treatment facility that is outside of the tribal system. So just wanted to put that out there too. And if you guys disagree with me on that, I certainly would be willing to discuss that some more. I want to learn, and I'm still learning. So be patient with me if I misspeak. Just briefly looking at the levels of care, these are tied into the ASAM criterion. So some of you may be very familiar with these, but just of this continuum of care from a 0.05 level of care all the way through to the higher levels, residential treatment and detoxification services. So that just gives you an idea of which level of care is attributed to which program. And these are universal levels of care. So these are consistent throughout the treatment systems all across the country. And perhaps you would see some of this replicated in other parts of the world. So here are the dimensions. Here they are. And I love the color coding, Kate, by the way. I gotta use that myself. That's great. So you have dimension 1, acute intoxication and withdrawal potential. Dimension 2, biomedical conditions. So this would be diabetes, or it could be any number of current or ongoing medical conditions, or lack thereof. You would rate this lower if there weren't any. Dimension 3 is emotional, behavioral, and cognitive conditions and complications. Dimension 4 is readiness to change, which we would say in the old days was denial, and now we say how ready, trying to determine the level of readiness that the patient is to make changes in their lifestyle. Dimension 5 is relapse continued use potential or problem potential, and then dimension 6 is this recovery or living environment, and that again is that really ties into that biopsychosocial sort of assessment and recovery capital potential for the patient in that dimension 6. Well, a polling question. What the Wow, I really went crazy with these, didn't I? Here we go. Which ASAM dimension is associated with determining a patient's willingness to engage in the treatment process? This one I actually told you before this polling question. So, oh yeah, you guys nailed it. Yes, there it is. I have some experienced clinicians listening in today. So wonderful. Yes, the answer is dimension 4, readiness to change. Fantastic. And I would just back up and say, I wonder what her level of readiness is to try a different hair color.
Steve, I just wanted to quickly mention that LaDonna had commented just, and I'm not sure if I quite understand what part of your conversation um, she was saying we disagree, and so I'm curious. Now she says because our DNA is different. So I don't know. Do you know what she might be referring to? And yeah, I'd love to just open up that discussion if others want to comment.
Sure, maybe it's related to amounts consumed, or I'm not sure, LaDonna, what that question is referring to. Or maybe we can talk about it. And I know LaDonna, so I've met LaDonna, and but I appreciate that, LaDonna. I just would probably need to know a little bit more what that's. Oh yeah, here we go. Yeah, she's asking earlier. I think is there a process to break down what meth is made of? I don't know if that's what she was referring to. That's there is. I don't know that we would probably have time to talk about that in this presentation, but certainly we can have a discussion about that. Um, there's some good questions on here. I'm sorry I haven't been real attentive to those, but we're going to hopefully try and come back to some of these. And so, LaDonna, I hope I can get to your question or address that. If we get a chance, okay? Whatever you disagree with me on, I respect that, and we'll see if we can't get to the bottom of that. Okay? Somebody says too I should get closer to my mic, so I think Kate has ordered me a headset or something, so I'm going to try that next time. Although that headset may get tangled up in my braids, and we never know what would happen then. Yeah, if I could only hear you guys laughing, it would be good. Is that better? Okay. So yeah, let's see if LaDonna does she responded to just to make sure. We can circle back. She's just saying our DNA is different. Yeah. Okay. Let's try and keep moving. So the risk ratings really are the risk ratings associated with those dimensions that we're talking about are on a 0 to 4 A and B rating. So 0 is no risk and 4 is severe risk. Um, it's these ratings act as a guide for the clinician, managed care providers, medical staff, and support staff. A rating of 0 may indicate no concerns or stable condition, and a rating of 4A or B may indicate a significant concern and the presence of acute conditions in the dimension. Does that make sense, everybody? Risk ratings are based on direct observations, current patient information, derived from a multitude of sources, as well as historical information from the patient's record and self-reports. The ASAM risk ratings, when assigning a risk rating in each dimension, remember, it may not match word for word. So when you look at the descriptions of the risk ratings, it may not match word for word. Just focus on selecting the risk rating that most accurately reflects the patient's condition for each dimension at the time of the assessment. Remember, we're talking now about the evaluation process. This may be an evaluation and a placement where you're referring them on to another facility. Risk ratings are not static. They will likely change over time. This is what we would call like a continued stay review. But the risk ratings at the time of your assessment will help decide the best level of care for the patient. So again, we're using the DSM criterion, we're using ASAM criterion, and we're using other collateral information to help us make a decision about whether a patient needs further care, and if so, what level of care are they in need of. Risk ratings for mental health disorders and substance use disorders are assigned separately in dimensions 4, 5, and 6, but will often interact and influence each other at the time of the assessment and or throughout a patient's treatment stay. So the dimensions 4, 5, and 6 afford the clinician an opportunity to give a mental health risk rating in addition to a substance use disorder risk rating to help better determine their overall treatment needs. So if we look at, well, we're not going to go through these completely because I think we just for time purposes, but the ASAM criterion, I wanted you to at least get a glimpse of, those of you that haven't seen this before, I want you to at least get a glimpse of what dimension 1 and how the wording goes for each risk rating. So dimension 1, remember, is acute intoxication and withdrawal potential. So you, at the time of your evaluation, are trying to assess what risk rating best fits the patient's condition. So you can see here there are different worded formats for each risk rating. So 0 would be fully functioning, no signs or symptoms. And then we can see progressively it becomes more acute. And then we see it breaking down into a risk rating of 4, which is the most acute and most severe. The patient is incapacitated with severe signs and symptoms. Severe withdrawal presents danger such as seizures. Continued use poses an immediate threat to life. So that's quite a shift from 0 to 4. But again, you're trying to assess in a unified, standardized way what their withdrawal or intoxication status is. Dimension 2 is the medical. Think of this as medical. Medical condition. Again, it's a stable 0 risk rating, or if you have some significant medical conditions that will impact or interfere with the treatment process, you may need to prioritize medical services before the treatment process can begin, especially if they are you're in an outpatient setting and you really don't have the capacity to treat medical conditions, even in a residential setting, often with the full nursing staff. There's only so much they can do in that setting if it's outside of the hospital. Dimension 3, I think this can get a little tricky. The way I was trained was really to look at Dimension 3, emotional, behavioral, cognitive condition. I'm looking here to see whether there is a current or past mental health diagnosis, formal mental health diagnosis. If there is not, I'm not assigning a risk rating, but I can make notes to the referral source or clinician reviewing the evaluation that there are perhaps some mental health concerns. If they have a formal mental health diagnosis, then I'm able to assign a risk rating accordingly. And we can see the risk ratings again on a 0 to 4. If there are significant high risk ratings for mental health issue or mental health disorder, then that really may need to take priority, especially if there is safety for the patient and others involved. Dimension 4 is that readiness to change. So this really is looking at both substance use disorders. You're assigning a risk rating potentially for both substance use and mental health disorders here. If the patient has a formal mental health diagnosis, I may assign a readiness to change risk rating for their mental health condition, in addition to their readiness to change regarding their substance use disorder. I know it sounds a little convoluted, but if you can think of the substance use disorder and the mental health disorder as oftentimes equally impacting one another, it's important to discern um, how ready they are to address their mental health versus how ready they are to address their substance use. And sometimes they differ. They may be med compliant and willing to go to their mental health counselor, but unwilling to give up alcohol or give up, whatever their drug is. Hope that makes sense. And we go through the risk ratings for these as well. And they're all on a 0 to 4, A or B. We see the A and B. A is certainly an acute risk rating, and B is sort of that next level on an even more acute or severe level. These would read through. You can read through these. You can find this ASAM criterion in a variety of places. If you're interested, I can make those available to you as well. Dimension 5 is that relapse continued use potential. This, I think, is extremely important when determining level of care. It would be ill-advised and inappropriate for me to place someone in a entry-level outpatient service if they have a risk rating of 3 or 4 in this dimension. They potentially would be, prone to relapse immediately versus saying, well, if a person has a risk rating of 1 in this dimension, that is, and we're going to look at some guidelines later, but that is, as it reads here, the patient has minimal relapse potential with some vulnerability and has fair self-management and relapse prevention skills. And you can see there's also a reading for the mental health disorder as well. But that would indicate to me that they would probably do well, coupled with other information I have about them. First treatment, meeting a mild substance use disorder, drinking 1 or 2 times a week, 3 to 4 drinks at a time, first OWI, family is not overly concerned. So I would be coupling that with this risk rating of 1 to make my treatment recommendation. Does that make sense? Yes, Joanne, I can make that happen. We can email me or reach out to me, and I will definitely get that information to you. Are we still catching an echo? Somebody said we're echoing. Roberta, are we still echoing? And Madonna, I agree. There are some unique aspects to native DNA. I'll agree with you on that. Okay, so we're not. Pamela says there's no echo, so maybe it's something going on there with Roberta's setup. I'm not sure. Let's keep going. I want to look at, and we can see the severity levels increasing in dimension 5. Dimension 6 is that recovery environment, trying to assess the support, the stressors, whether the support is passive or engaged, really trying to determine that, especially if I'm looking at what level of care, what level of treatment care is a best match for this patient. If they are homeless, they have no supports, they are having difficulty meeting those basic needs, then they may be more appropriate for full-time placement. Or if they really have continued to struggle due to lack of supports, I'm going to want to make a higher risk rating. And as we can see, I may make a risk rating in dimension 6 of 3. patient's environment is not supportive of addiction recovery. He or she finds coping difficulty even with clinical structure, and this gets even more pronounced in a rating of 4A or 4B. If I am calling an insurance company and trying to pre-cert for a residential placement, they will ask me, what are the ASAM risk ratings? And if I do not have a 4A or B in at least one of those dimensions, they likely will not approve a residential placement. It's something to keep in mind. There may be exceptions to this, and I know that that is not a factor when making referrals internally within tribal treatment centers, but I know that this is a big factor for managed care and other insurance companies when trying to agree to cover treatment costs. Polling question, true or false, ASAM's 6 dimensions and 0 to 4 risk ratings are designed as a standalone assessment tool to guide the clinician in determining diagnosis and course of treatment. True or false? Here we go. It's coming in. Looks like there's a little more indecisiveness on this one, but overall, you guys are pretty close. Pretty close. A couple more minutes here. Okay. Yeah, so it looks like a couple of late decisions here. Okay. Okay. Yeah, looks like Lori is giving us a pretty good indication. Thank you, Lori Gomez. Yes, the answer here is false. It is not a standalone system. It is a supplement. It is to be coupled with the other assessment tools. But it really, again, it's really about acting as a supplement, some standardized guidelines to assist the clinician in the level of care placement and needs and course of treatment. And it allows the clinician, as I said, to monitor progress, justify the level of care change, including referral to a higher level of care, or discharge or transfer from the current level of care. It is something that can be utilized across treatment centers to maintain consistency and reliability. So again, we're not going to be able to spend a lot of time here, but I did want to at least show you the levels of care and how they connect to these ASAM risk ratings. It's really important because the risk ratings are an assisting factor to help the clinician determine what is the best level of care. So 0-5 we know is this early intervention. It's somewhere between prevention and this level 1 entry level treatment. But I would say, if I'm looking at this, there really should not be any risk ratings or even a formal diagnosis for a substance use disorder in this patient. We should see zeros, maybe a 1, but likely just 0 risk ratings if the person is appropriate for an early interventions service. Level 1 outpatient, this is that entry level sort of psychoeducational. These therapies would include a variety of different things, but it's an entry level concept. And I would say that if I'm looking at making an outpatient recommendation from an ASAM risk rating perspective, I would want to see 0s, 1s, maybe a 2 in one of the risk rating one of the dimensions, but certainly nothing beyond that. Level 1 outpatient, sort of this dimensional admission criterion. So again, we're not going to have time to dig too far into this, but if you look at the dimensions and how they relate to the outpatient treatment level of care, we can see that dimensions 1, 2, and 3 are going to be risk rated fairly low. Dimension 4, I think, again, would be rated low. Willingness, willingly engaged or willing to enter treatment, that's either a 0 or a 1 rating. Dimension 5, sort of looking at how likely it is that they would continue using. Now, lower levels of care sometimes involve patients who have, you know, are low or may not be ready to make changes. So they may continue to use throughout the treatment process or struggle with that idea of complete abstinence. Most treatment centers are abstinence based, but that might be someone you would work with individually and maybe do some risk reduction with or something along those lines. So again, we would look at level 1 through those criterion, asking ourselves some of these questions as we give a rating, a risk rating in each dimension when considering outpatient treatment. Level 2.1 is intensive outpatient, as some of you probably know. And again, I would go through the same process here, looking at whether or not they are attaining risk ratings in each of these dimensions. And I generally, when I was training clinicians or when I was doing evaluations, I would look, if I was considering intensive outpatient, from an ASAM criterion perspective, I would often look for at least one risk rating of 3 to help me determine and guide me in determining whether or not intensive outpatient is appropriate. Again, it's not a standalone determinant. I'm looking at diagnosis, previous treatment history, current use, amount of frequency, level of support. If a patient's been through a lower level of care and they've returned for another evaluation, I need to look at, depending on how much time has passed, the next level of care, and I'm going to look for my ASAM dimensions, my ASAM risk ratings to support that diagnosis. If I'm calling the insurance company or I'm trying to make a case to the patient as to why I'm recommending a higher level of care, it's a really wonderful way for the clinician to back up their decision-making process, in addition to the other diagnostic components. So again, when we would go through and look at these different dimensions and looking at how those risk ratings affect each dimension when considering outpatient, intensive outpatient. And again, we would see this repeated when talking about level 3.5, which is that residential placement, or a 3.7, which is the detoxification level of care. But I'm going to go through these and ask myself some of those questions, seeing whether or not that risk rating is impacted by how this dimensional admission criterion is affected. And we can see we work right through those dimensions when considering residential placement. Again, I would say that if I was looking to place someone in a residential facility, in addition to some other components, I would also look for a risk rating of 4A or 4B in at least one of 6 of those dimensions. One of those dimensions should have a risk rating of 4A or B. When I call the insurance company, they'll say, what are the risk ratings to support a residential placement? And I can say they have a 4A in dimensions 5 and a 4B in dimension 6. And as those are described, those are severe and acute conditions that garner that high level of risk rating. Just briefly, I wanted to talk about withdrawal management overview. Withdrawal management is very, very hot item right now with a lot of the opioid issues we see spreading across the country and continuing to do so. The withdrawal management overview is important. I think just to note that there are levels of placement care depending on the patient's level of withdrawal and the risk ratings associated with that. So here we would look at these different components when assessing withdrawal management, especially if we're talking about opioid use disorders, OUDs, but certainly other substances could play a role in that. There are some licensing and certification requirements to prescribe certain medications like methadone or Suboxone. I don't think you need to have a specific certification to prescribe naltrexone, um, but still, that isn't always the best match for the patient. Polling question: if a patient has a risk rating, if a patient has at least one risk rating of 3, which level of treatment care should be considered? If a patient has one risk rating of 3 in those 6 dimensions, which level of treatment care should be considered? And again, this would be coupled with other information, but just as a general rule, which level of care would I consider? I'm seeing some great questions too. Yeah, Marcita, I think that's a great question. I think there would be a place for that, probably in Dimension 6, looking at traditional healing ceremonies. That to me, that would be really, really big part of a patient's recovery capital. That insulating factor, that culturally specific insulating factor. Yeah, I think that's great. Great question, and I think yes. My answer is yes. Um, yeah, Carlos, I appreciate that too. He says some data about long-term effects of early initiation upon later life outcomes, so we welcome as well. And I don't know if you're talking about age of onset. Um, I know age of onset is a big predictor for prognosis later. Um, I don't know if that's what you're referring to exactly. But yeah, that's probably a discussion we could have too at a later time. Yeah, art therapy. I like that. Um, yeah, Michael, depends on the intermediate concern and the dimension which interferes with current placement or level 1 placement. Yeah, yeah. I think I understand what you're saying, and I would agree. Uh, yeah, age when first started using that's what I would call age of onset. So when did they first report using? Like I started smoking. A patient might say I started smoking cannabis with my big brother when I was 11. Uh, that's going to look very different uh, than the patient who started smoking cannabis when they were a sophomore in college. It's going to have a vastly different impact on that patient's outcome, at least theoretically. I like that, Ladonna. I agree. Uh, Big Fire is right. We are. It's the spirit and the soul, and it's right. That's where the healing begins. It's from within. I'm with you, sister. I'm with you. Okay, let's keep going. The polling question. The answer is intensive outpatient. I would want to see a risk rating of 3 in one of those dimensions to support uh, a level of care for intensive outpatient. There's always exceptions, but that's my general guideline. And here are those guidelines. So remember, these ASAM risk ratings can assist the evaluator in making consistent, accurate, and objective decisions about a patient's level of care and related treatment services. There will always be exceptions to these guidelines, but I just wanted to kind of lay those out just to give you kind of a quick snapshot of how I would start to familiarize myself with the risk ratings, that's the RR, and how they relate to the levels of care that we're trying to determine whether or not a patient is appropriate for. Okay. Kate, where's my slide count? How close am I? I can't tell which slide this is.
I think we just have a couple more. So,
Okay, yeah,
yep,
I
just
don't
two
want
more
to just
after this.
trying to stay as close as I can to the timeline. So I know everybody's busy, and I really appreciate everybody staying on, and it's really it's really appreciate that. So clinical evaluation assessment summary, assessment process, assessment instruments, DSM-5 diagnostic criteria, and the ASAM levels of care and criteria. We made it. I can't believe it. Sometimes I amaze even myself. Let's do a few questions. I put some links up here. If you guys, there's some links to ASAM. Uh, Dr. David Mealy is sort of the guru for ASAM. He really is a great resource. I've had the chance to meet him a couple times. Um, yeah, I'm trying to see if there's any questions. Kate, do you see any questions that jump out that trying to see? I tried to get a couple of them earlier. Yeah, Eric, risk rating 3 are usually aligned with residential treatment unless an override is done. That's interesting, Eric. Yeah, I was always trained that 4A or B was required for a residential placement. Um, but that again, there may be some more factors involved there. Um, Oftentimes, I could even have a 4A, and if the patient is not attempted treatment at a lower level of care, uh, managed care will not approve the residential stay until they've attempted outpatient first. But that's interesting. Yeah, I didn't know that there was variation in that.
I noticed someone asked about the PowerPoints being available after the webinar, and I just want to let everyone know that we will send a follow-up email to everyone who attended, and that will include handouts of the slides as well, so you can review them later. Steve, someone asked actually like towards the beginning when we were talking about drug testing, if there were any instant tests for opiates or anything like that, like a breathalyzer for alcohol, if you knew of anything like that.
Yeah, the closest that I would say you're going to get to a quick test would be like a panel screen, which is like I call it a dip test, or where you're literally soaking up the sample in some wicks along a panel, and then looking for the chemical reaction. But remember, on-site screens are not official or submissible in court. You would have to send that in for a confirmation if you had a positive. In our clinic, we would always send in a positive to confirm and rule out a false positive, because there are some things that can trigger false positives that are not drug related. I don't know if that gets to your question, Craig. Craig was asking about alcohol tests, and I think the breathalyzer and my sniffer were always the best ways to determine. But um, screening alcohol in the urine is unreliable. It's metabolized very quickly, and occasionally we would request it on our lab screen, but it was usually if I wanted to determine whether a patient is drinking in excess in a detox setting, we might do a blood sample and check their liver function testing and some of their other liver enzyme levels to see if that organ is working real hard to process those toxins. But yeah, alcohol screening. I think the breathalyzer is, a handheld breathalyzer is really the best way to go. And doing those randomly, or if you have probable cause, I think is really the most reliable and effective way.
Steve, maybe you saw this one and I didn't hear you reference it, but Marcita Eaglebear asked about equine therapy and traditional healing ceremonies fitting in at any level, and asked your opinion on that. And I just wanted to say too, I'm going to put up a link as soon as I find. We have a webinar that Ed Parcells, who I know works with Marcita, did on equine therapy. So I'll link to that here in the chat just a second.
Yeah, Ed Parcells is one of our advisory board members. He is a Lakota Sioux tribal member in South Dakota. He's down in Rosebud and runs a native methamphetamine clinic there, and has done a lot of equine therapy as well. And as I said earlier, I think those would all, to me, fall under that Dimension 6, and determining that as a supportive recovery-based support service, within that cultural community. I think there's a lot of merit to that, and that would help me determine how likely it is the patient can sustain their recovery, especially after their post primary care, following their primary care. I think if I saw another one in there. Yeah, a poll question about from Winnebago, who said to give birth to the ancient in a new time is creation. The task is to give birth to the old in a new time. Interesting. We want to make that a poll question, Lana? I'm trying to think. Did I miss anybody on a question there? These have been great, you guys. I really appreciate you hanging with me this afternoon, and thanks, Jackie, for the laugh about my collecting large quantities of urine in my career. I really appreciate that. I really have just 30 milliliters at a time. So I do want to just again thank everyone, and happy to take some additional questions via email. Would really like to spend more time looking at some of these other questions, but I know everybody's got things to do. I just want to take a minute to say thanks to Creator, and may He bless and protect all of you as you go throughout your day and the rest of your week. And I'm just honored to be able to share some of my knowledge with you as I continue to grow and learn about Native cultures. So thanks for your time and your efforts and your interest. And we're going to meet again. We're going to do this again next month. We'll talk about evaluation and treatment planning. So we're going to build on what we talked about today. So hopefully catch you guys next month, and we'll have this conversation again. Until then, I would just say take care of yourselves. And how do they say in Lakota? There's no word for goodbye. I think it's Toksa Ake. So long, everybody.